Good afternoon, everyone. As I introduce myself, I'm Amy Gschopf. I'm an oncology practice transformation manager with Integra Connect. I'm an oncology certified nurse, and over the last 12 years or so, I've had the opportunity to work in a variety of different settings: inpatient, outpatient, navigation, leadership, quality, most recently as the survivorship program manager at St. Luke's Cancer Institute in Boise. I transitioned to Integra Connect into my current role in December. And I now have the exciting opportunity to partner with oncology practices across the country to optimize their workflows, improve the quality of care that they deliver, and support their successful participation in value-based care models. So it's pretty exciting. I definitely miss my team at St. Luke, so I love being on these. I get to see a lot of you on here. But I'm really excited to be here today and discuss why the phases of cancer survivorship matter. So we can move on to the next. So by the end of this session, my goal is that we will all be using the same language when we talk about survivorship. Specifically, we'll define cancer survivorship, we'll review the main phases of survivorship, and then apply those phases to clinical practice. We can move on to the next slide. All right, so to start, according to the National Cancer Institute, cancer survivorship is a state of being that encompasses perspectives, needs, health, physical, psychological, social, economic challenges experienced by both patients and caregivers following a cancer diagnosis. They also define an individual as a cancer survivor from the time of diagnosis through life. So that includes those living with cancer, living without cancer, and those nearing end of life. So we can really come to the conclusion that survivorship care begins at diagnosis, and survivorship care really is at its core, especially as NCI defines cancer survivorship. It's really caring for the whole person by addressing all of those listed by the NCI definition across the cancer continuum. So it really is at its core supportive care. Survivorship care is supportive care, and it should start at the time of diagnosis and continue through the end of life. And it does not begin when treatment ends. So despite how clearly survivorship is defined and has been defined for many years, many patients unfortunately do not experience care this way, and that gap is why this conversation is necessary. So we can move on to the next slide. So as I mentioned, survivorship is still often treated as a single post-treatment phase, something that happens after treatment when the patient's considered quote unquote cancer-free. But in reality, patients' needs change over time. They change through treatment, disease status, and survivorship care really should support these changes from the very beginning. And that's why that NCI definition matters. When we mentally limit survivorship to just post-treatment, we unintentionally exclude many patients who are actively struggling. And when we don't anticipate how needs change during the cancer journey, we end up reacting to crises instead of proactively preparing for them. And we'll talk a little bit more about that. But that's why this conversation is necessary. The phases of survivorship really give us a framework to match the right care to the right time, rather than waiting until problems emerge. And I like to remind myself that cancer care doesn't end when treatment ends, it just changes. And we'll again talk a little bit more about that later in the session. So we can move on to the next slide. So the survivorship continuum is often described in three broad phases. You might see them titled a little bit different depending on what you're looking at. But we really want to think of these as lenses, not necessarily rigid timelines. And the purpose really is simply to help us match care to patient needs as they change over time. So first we have the acute or early phase, the period from diagnosis through completion of treatment. We have the extended or post-treatment phase, from treatment completion through active surveillance. And this phase is typically around 5 years, but the length is really dependent on the patient's risk of recurrence. So that can definitely vary. And finally, there's the long-term phase, and this begins after active surveillance and continues until a patient experiences a recurrence, develops a new cancer, or reaches end of life. And so it's really important to remember that patients can move between, yeah, thank you. We can move between these different phases depending on progression, recurrence, those type of things. It's really not linear. And I also want to emphasize that this framework isn't about labeling patients. It's really, again, about matching the right care to where a patient actively is in their cancer journey. And again, we'll talk more about that and what it looks like in practice next. All right, so as we discussed earlier, survivorship care is supportive care and it begins at diagnosis. And so this slide is just the intent is just to offer some very high level examples of common supportive care needs across the different phases. It's not a complete list whatsoever, but just some, again, high level examples to get us thinking about the different phases. So we have the acute or early phase. So we're looking at symptom control, emotional safety. I bolded proactive, late and long-term symptom control. That one's really important. Quality of life should also be bolded, as well as long-term goals. In the extended or post-treatment focus, we're looking at adjustment, fear of recurrence, some identity, body image changes, returning to work, those sort of things. And then in the long-term focus, we're looking at late effects, function, sexual health, cardiovascular risk, quality of life, those sort of things. We can move on to the next slide. So this is where it becomes clinically relevant. Same diagnosis, different phase, different needs. And so the same patient may ask very different questions or sometimes no questions at all, depending on where they are and what phase they're in. And the same symptom might represent different things, acute toxicity, emotional distress, or even a late effective treatment, depending on the timing and the context. So an example of this is fatigue. So during treatment, it may be an expected toxicity. After treatment, it may reflect possibly emotional distress, maybe fear of recurrence, sleep disruption, all sorts of things can take place that cause fatigue there. Years later, that same fatigue could be a late effective treatment, maybe some cardiopulmonary changes, things of that nature. So the symptom may not change, but the meaning does, depending what phase of survivorship they're in. We also know that distress often increases after treatment ends, and at that moment is when routine support begins to decrease, and we'll talk a little bit more about that shortly. But when we're aware of the survivorship phases, we're better able to anticipate patient needs. So next, we're going to walk through a patient experience to kind of see how this plays out. So I want to introduce you to Sarah. She is 38, treated for breast cancer. She's had a double mastectomy, and she's a single mom to one daughter. So clinically, her diagnosis is the same, but she's a very different patient in each of these survivorship phases. So we'll walk through each of these three phases with Sarah. So during the acute or early phase, Sarah's life feels like it's completely on hold. There's information overload, fear of dying. She's having physical side effects and decisions that feel urgent and overwhelming. She's also a single mom with a daughter, so all of this is just extremely overwhelming. She shares her experience as, I'm just trying to survive. I don't even know what questions to ask. I just want to get through treatment and beat this cancer. During this phase, patients often rely on providers to help them understand what is normal, what is not normal, what symptoms to report, which may lead to side effects either not being reported and going unaddressed. So they often struggle to process or retain long-term information. And emotional distress is high, but it's not always expressed. They're kind of in this survival mode, as Sarah expressed here. But as Sarah moves forward, her needs don't disappear. They just change. So let's talk about the next phase. So moving into the extended or post-treatment phase, this is often the most misunderstood phase for patients. Treatment has ended. Her visits are less frequent. She was seeing someone from her oncology team every 2 to 3 weeks, and now she's seeing her oncologist every 3 to 4 months. She's returned to work. The support from family and friends has faded since it appears she is quote unquote back to normal. She reports being told over and over, you did it, you beat cancer, you're done. But in reality, she has finally begun to face what she has been through, the emotions, the fears that were all pushed aside during treatment when she was in that survival mode now begin to surface. She's now processing that. When she no longer feels like she's actively fighting her cancer. Her fear of recurrence has now set in. She feels like she's kind of a sitting duck, not actively doing, just kind of waiting. And now every ache has her believing that her cancer is back. She's not allowed to just have a headache anymore. She's also adjusting to changes to her body image and identity. Her hair has grown back straight when it used to be curly, something she loved about herself and something no one told her might change specifically. She knew she would lose her hair, but had no idea that something like this could happen. She's also had a mastectomy. She has scars, and when she looks in the mirror, she just doesn't recognize herself. So while others might see recovery, Sarah's still trying to make sense of who she is, this new normal. The end of treatment is not the end of impact. It's really the beginning of an adjustment to a new normal. And for many, this phase isn't about just moving on. It's about really learning to live with what remains. And that carries forward into the long-term phase that we will see next. So in the long-term phase, cancer history can just kind of quietly fall off the active problem list rather than being treated as a chronic condition. But as we know, its effects do not. We know that late effects surface years after treatment ends, and new symptoms may be misattributed to things like stress or aging or other comorbidities rather than recognized as a true consequence of prior cancer treatment. And for Sarah, this phase brings on continued fatigue, sexual dysfunction, and now new cardiac issues, symptoms that she didn't even realize were connected back to her treatment. She's also experiencing ongoing financial toxicity. She unfortunately never recovered from the financial burden cancer brought on. And with the chronic stress combined with the trauma of her experience, it's contributing to ongoing anxiety. So she shares that she had no idea life after cancer and cancer treatment would continue to be so difficult. After all, she beat cancer, right? She did it, she's done. But looking back, she really wishes she had been warned earlier, as well as more frequently throughout her journey about what the different phases might look like over the long term. Be a little bit more prepared. An example of this that Sarah doesn't recall being educated about is that sexual health concerns can be a common effect of cancer treatment and not a personal failure, which is what she thought all of these years. And looking back, she assumes her provider brought it up early in treatment, but at the time was not a priority. She was in survival mode. And because it wasn't brought up again throughout the different phases as she moved forward, when it did become a priority concern for her, she assumed it had nothing to do with her cancer or the treatment and attributed it to other things going on in life, age, those sort of things. So we know that sexual dysfunction is common, and it's unfortunately not commonly reported. They may not bring up these concerns to their provider unless their provider does. And even then, some patients may not be comfortable having that conversation. We also know that patients struggle with retaining information long-term, as we learned about in the acute phase. And so really early and continued acknowledgement of these type of things, especially sexual health concerns, can really reduce shame and isolation and kind of normalize that side effect. So Sarah's felt pretty alone in her experiencing, wondering what's wrong with her, what's wrong with her body. And in Sarah's case, early proactive supportive resources, sex therapy, pelvic floor therapy, medications, whatever it may have been, could have really helped Sarah earlier in her journey. Instead, this issue went unaddressed until she finally decided to seek help. And it's a great example of why that continued education is so important. Even if they appear fine, even if they dismiss symptoms, it's still important to bring these things up. And so Sarah's experience isn't unique, but it does tell us why understanding those survivorship phases matter. So what we've seen across her journey is that the needs don't disappear as time passes, and they do not automatically get better. They just change. And without looking through that lens of the survivorship phases, those changing needs can be easy to miss. We can move on to the next slide. And so, why do these phases matter? So we've learned through her experience that cancer is not experienced as a timeline, it's ongoing. It can be an ongoing experience of losses, fears, adjustments. Their needs don't change even when the diagnosis, or their needs do change even though their diagnosis doesn't. Distress often peaks after treatment, not during. And many of these needs are predictable but easy to miss unless we intentionally look at where a patient is now, what phase are they in, where are they headed next, and really walk alongside our patients, offering that support and continued education. And so when we recognize survivorship as a continuum, or I should say recognize survivorship care as a continuum, we really improve how we listen, what we screen for, how we support our patients over time. And so really understanding the phases of survivorship help us support patients proactively rather than reactively. Knowing that distress and fear of recurrence often intensify after treatment allows us to really prepare our patients in advance, educating them on what to expect, connecting them early to supportive services such as support groups or individual therapy, and again, walking alongside them through the transitions rather than waiting for our patients to identify a problem or maybe not even identify a problem and ask for help. This can help them really feel less alone when they get there. We can move on to the next slide. So before we close, I just want to bring us back to really what the intent and the core message is, that survivorship care is supportive care, and it needs to begin at diagnosis. From the very start, our job is to support the whole person and to look ahead so patients are prepared for the phase that they're in and the one that's coming next. It doesn't mean more visits or more tests necessarily. It's just really about timing and our intention. It means we anticipate and plan for needs rather than react to crises. Education isn't a one-time thing. We revisit key topics as patients move through phases, including those concerns that they either minimized or maybe didn't express. And it means we listen differently based on where a patient is on the survivorship continuum. We screen throughout, especially during transition and after treatment ends, looking intentionally for distress, sexual health, sleep, other concerns. And when new symptoms arise, even years and years and years later, we really bring cancer history back into the conversation. And so survivorship truly is built in the moments that we already have with our patients. It's really how we listen, how and when we educate, when and what we screen for, how we prepare for patients for what's next. All of these intentional small moments, it really is the survivorship work. Like these are the moments of survivorship work. And so the goal isn't necessarily to do more, it's really doing the right things at the right time and for the right reasons so that patients are prepared and not surprised. Thank you all. Happy to take questions or hear your thoughts.
Amy, thank you so much. That was a fantastic overview here. We're going to pause. If you have questions, you can unmute or you can use the chat to put those questions or comments there. Thanks, Daniel. Let's start with you. So does memory loss typically present as a symptom for survivors? And if so, how do you help the clients cope with that?
Good question. We have a doctor on the line.
It's a really common long-term side effect of all the toxicity, especially if patients had radiation to the brain, that sort of thing. So it's almost an inevitability to some degree for a lot of the chemotherapies that we use. I wouldn't say that's a common presenting symptom for like disease recurrence. And so in your patients who are having that like new onset memory loss, I don't know if My first thought would be like recurrent cancer or anything like that. But definitely patients who have undergone any kind of cancer therapy are at increased risk of dementia later in life and other memory loss syndromes for sure.
Thank you.
Amy, I was wondering if, especially thinking of our case even from the last session and the communication challenges, especially for a rural provider, do you have any pearls of wisdom on how, especially like the specialists and those rural providers can communicate and support the patient through these transitions?
It's like the golden question that everybody's trying to figure out. It's so difficult. I think what I kind of went back to after that conversation is thinking about the survivorship care plan. And again, this typically isn't created until after treatment is completed. But something that has been discussed quite a bit is figuring out how to make this a living document. I have no idea what that would look like, but if a patient kind of had an updated, care plan, and so every time they went to a different specialist or a different doctor, they kind of had that care plan with them. That kind of gave an overview of what's going on. At least our care plans at St. Luke's gave a little snapshot of their diagnosis, any hospitalizations, medication, drugs, chemo, I mean, all the things, as well as what we're actively treating, what we're working on, what the plan is. So that rule is tough. That would be the only kind of idea. But again, that can be difficult to execute, and it relies on the patient to then take the care plan with them with each office visit. That's a tough one, though.
I might also jump in with an idea too. One thing that I think we all work on a lot is cultivating additional resources and folks to reach out to. And I think there's a lot of this stuff that can be provided either remotely to patients for some specialties, or it can be provided in the form of handouts, additional information, kind of depending on patients' learning strategies. And so kind of cultivating that network of resources can be a big piece as well, and knowing kind of who to plug into. So I think certainly reaching out to any of us who are working in this group pretty routinely, or in any of these sort of systems based models, we're going to have a lot of those kind of on hand probably too, and would always love to pass them along.